talk about, this is latest guidelines of January 23. So I think you will love to probably see it. These are India guidelines for the management of male infertility brought about by the Urological Society of India in January 2023. I brought this particular thing because gynecologists go blank when it comes to male infertility. And they are really worried when they see a patient of male infertility. These guidelines probably will be of quite a use to you people, because now we want each one of you to investigate your patients on these guidelines. Now, infertility is the inability of sexually active, non-contracepting couple to achieve a spontaneous pregnancy in 1 year time. As far as the global incidence is concerned, there is no reliable figures for the global prevalence of infertility. It is estimated to, again, around 50-50% between male and female. As far as the guideline statements are concerned of this January 23 guidelines, they very clearly emphasize on a couple workup. To categorize infertility, both the partners should be investigated simultaneously. And this is a moderate recommendation. As for the incidence is concerned, as per an Indian report, 50% of infertility results from reproductive diseases in men, and 25% of infertility cases have no clearly defined etiology and are termed as unexplained infertility. In India, the primary incidence of male infertility could be defined around 40% in female, 40% in male, 10% their both partners are at fault, and in 10% there is no causes found. Male infertility can be grouped as non-obstructive, obstructive, and coital. The reasons in 75% cases of oligospermia remained unknown. As far as semen analysis has been concerned, this had been a solo investigation, a solo workup as far as the male infertility was concerned. Relevant reproductive clinical history, the examination has been given a great importance, and it has to become integral part of the couple workup. Perform semen analysis as per WHO lab manual for examination and processing of human semen. And to information of all of you, there is manual has come in 2021. That is the 6th manual. And it's a big manual. I think each day the people who are want to become infertility expert should read at least 10 pages. So at least you go through it completely. As far as the blood endocrine profile and the semen analysis correlation is concerned, it is said that offer blood endocrine profile only if semen analysis is abnormal on at least 2 occasions. Again, very strong recommendation. Imaging is hardly ever done in male infertility. But as for the ultrasound evaluation is concerned, these guidelines say that ultrasound scrotum for patients who are obese with previous scrotal surgery or have tight, small scrotum, it should be done. As for the transrectal ultrasound is concerned, it is offered only when there is ejaculatory duct obstruction is suspected. Now coming to obstructive azoospermia. For patients with non-palpable VAS, whenever the andrologist reports this, suspect congenital bilateral absent VAS difference. This should be suspected and CFTR mutation should be tested. As far as testicular biopsy is concerned, we all know that testicular biopsy is not only diagnostic, it is prognostic and it is therapeutic. Diagnostic testicular biopsy should be preferably done in a center where in IVF, advanced and IVF center, where there's a facility for sperm retrieval and cryopreservations are available. So whenever you find that the sperms are there, one can freeze them for ICSI. Vasography is the investigation to determine the patency of the vas. The vasography should not be used as a diagnostic procedure alone and only to be used intraoperatively before reconstructive surgery. Now this has come as a strong recommendation. People or the couple gets upset when their investigations are too many. Now, as for the microsurgery is concerned for obstructive pathology, it is now related with ovarian reserve. In men with the female partners of good ovarian reserve, microsurgical vasovasostomy or epididymovasostomy for azoospermia due to obstruction in epididymis or vas respectively can be performed. When there is a good reserve, then one can go for these reconstructive surgeries. But whenever the ovarian reserve is low, the sperm retrieval techniques such as PISA, TISA, TC, MESA can be used in place of reconstructive surgery. Whenever there is irreparable reproductive tract, for patients, it is recommended that sperm retrieval techniques are preferred for ICSI and IVF. Again, strong recommendation. Men with ejaculatory duct obstruction and dilated ejaculatory ducts may benefit from transurethral resection of ejaculatory ducts, which is oftenly referred as TERD. Again, a strong recommendation. Now, whenever you find men with suspected ejaculatory duct obstruction, but a normal transrectal ultrasound findings, are likely to have fibrous type of ejaculatory duct obstruction. This is post-infective in majority of the cases, and they are not candidates for TERD and will need PISA followed by ICSI. Again, strong recommendation. As for the non-obstructive azoospermia is concerned, patients should undergo comprehensive assessment, including detailed medical history, examination, hormonal profile, and genetic tests for assessing the etiology. Again, strong recommendation. Now, we all know about Y chromosome microdeletion test is also becoming part of the investigations whenever we deal with cases of azoospermia and severe oligospermia. It is said that in men with zone fertility A and B microdeletions, the surgical sperm retrieval is contraindicated because you will not find any sperms in these two categories. While if it is C, these patients present with azoospermia or oligospermia, and sperm retrieval will yield significant number of sperms in 55 to 60% of cases. As far as TISA and micro-TISA is concerned, here I think all gynecologists should know that in 80% of cases of azoospermia, they can father their own child. There's something like open biopsy, which an ordinary infertility expert or IVF expert can do it in their own centers, and you'll find in 50% of cases, the sperms will be retrieved, which can be saved. In those 50% of cases where the sperms are not retrieved after doing open biopsy, they must be referred for microdissection, micro-TISA. Because in these 50% cases where an ordinary IVF center, they could not find it, by microdissection TISA, they can again find it in 50% to 60% cases, the sperms can be retrieved. This is again a strong recommendations. So, knee-jerk reaction, whenever they have an azoospermia, कि आपको donor sperms लेना पड़ेगा, that's not to be done. Good 80%, 85% of cases, these men can father their own child. Now, as far as hypogonadotrophic hypogonadism is concerned, this diagnosis is very favorable because ART use can definitely treat the infertility. Male hypogonadotrophic hypogonadism is a failure of testes to produce androgens and the sperm secondary to congenital or acquired diseases affecting the hypothalamus and or pituitary gland. The diagnosis is confirmed by the low serum FSH, LH, and testosterone levels. Imaging by MRI and CT of the brain should be done. Again, very strong recommendation. And clinical features depend on the age of presentation. Now, as for the treatment is concerned, whenever fertility is not desired, the treatment is androgen replacement therapy. But people who are desiring to have fertility, gonadotropins are started to stimulate spermatogenesis. As you all know, that initially we give HCG, which acts on the Leydig cells, and they produce androgens. When the androgen amount becomes normal, they add FSH. Then androgen plus FSH is going to act on the Sartori cells, and the sperm production is very easy. The people who are expert, they say that it just takes 6 to 7 months time for the sperms to be retrieved in good quantity. Androgen replacement therapy must not be done for management of infertility. I repeat again, because this is not to be done. We'll take a separate class sometime on this. Hypogonadotrophic hypogonadism is one of the rare conditions in which the specific medical treatment can reverse infertility because it has got a very favorable as far as the results are concerned. As for the infections in male infertility are concerned, infections have been associated with male infertility, but direct causation has not been proven. I again repeat, the direct causation has not been proven. Antibiotics, anti-inflammatory agents like NSAIDs, up to 3 to 6 weeks may have a role in the management of male infertility, especially in cases of complex prostatitis, prostovasculitis, and prostatrovascular epididymitis. There is a weak recommendation. Similarly, antioxidant therapy in the presence of epididymitis to restore reactive oxygen species balance after resolving infection and inflammation may be used. Now, as far as genetics in male infertility is concerned, we all know that 15% cases of azoospermia and 5% cases of severe oligospermia have a genetic problems underlying. This incidence may be 5% more. Whenever there is an elevated LH and FSH in men with azoospermia, it should prompt for a genetic testing. Moderate recommendations. Whenever the sperm concentration is less than 10 million, especially less than 5 million due to idiopathic spermatogenetic defects, should be referred for genetic counseling, karyotyping, and bi-chromosome microdeletion. Non-obstructive spermia will often require microdissection, TZ, for best chance of sperm retrieval. As for the Klinefelter syndrome is concerned, in men with Klinefelter syndrome, the chances of sperm retrieval at microdissection TZ is around 25 to 50%. Majority of the gynecologists say that, you are totally infertile. I think we need to revise our knowledge and skills. The chances of transmission of Klinefelter syndrome to offspring are low. This again, we must remember as far as the counseling is concerned. Young men with zone fertility C deletions require genetic counseling regarding the transmission to the offspring. They have better chance of sperm retrieval up to 55% on microdissection TZ. Whenever there's a low volume ejaculate and there is an acidic pH, absent fructose suggests obstructive azoospermia, and most commonly it is due to congenital bilateral absence of vas difference or EDO. Congenital bilateral absence of vas differens contributes up to 30% of men with obstructive azoospermia. It's a clinical diagnosis made by the absence of bilateral vas and palpation by the andrologist. The most common genetic evaluation for this condition is CFTR gene mutation evaluation, both for husband and wife. Because comprehensive testing in the couple is necessary to avoid CF child. Sperm retrieval is successful in up to 97% men with congenital bilateral absence of vas differens by testicular sperm aspiration, and especially the epididymal aspiration, which is just about 5 minutes procedure to retrieve the sperms. Now, as far as varicocele is concerned, all of you know about it. Only clinically palpable varicocele requires treatment. And some people even say that whenever it is grossly seen, that category requires treatment. Microsurgical varicocelectomy is the preferred modality of treatment. Whenever there is an unconsummated marriage, it may be due to erectile dysfunction or a female factor such as vaginismus or dyspareunia and lack of understanding of reproductive anatomy, perform office sildenafil test to assess erectile function. If this fails, consider office intracavernosal injection of vasoactive drugs as the next step to identify vasculogenic ED if unresponsive to these oral drugs which are used by the urologist. In men with vasculogenic ED requiring this particular drug or not responding to any non-surgical options, the shared decision making should be done along with patient for the role of penile prosthesis implantation as the treatment option. And few urologists are trained for this particular treatment. Testicular microlithiasis is associated with the abnormal semen parameters, but direct causation cannot be proven. I do not know much about this particular condition, but testicular self-examination must be taught and encouraged in patients with microlithiasis. I will ask Dr. Brigadier Sharma to comment on this. Now, as for the cancer and infertility is concerned, cryopreservation is mandatory and counseling should be done for all cases regarding fertility, future fertility options in almost all cases, which can easily be done once the person has attained puberty. As far as the testicular removal is concerned, should not be delayed in the process of fertility preservation. The risk of hypogonadism should also be explained, and the baseline hormones should be established, will clearly establish the diagnosis. Oncotese is an option in rare cases with azoospermia and bilateral testicular tumors. As far as undescended testes is concerned, testicular biopsy should be done during orchiopexy to rule out malignancy. The sperm retrieval with TISA may be done in undescended testes with azoospermia. And lastly, unilateral undescended testes shows paternity similar to that of a normal individuals. Now, as for the idiopathic infertility is concerned, before labeling an infertile male as unexplained or idiopathic infertility, all other causes should be excluded. Idiopathic and unexplained infertility do not have definitive treatment. We all know about this. And as for the empirical medical treatment is concerned, it consists of two broad categories, that is hormonal and antioxidants, which can be offered to these patients. Moderate recommendations. Empirical medical treatment should be offered initially for at least 4 to 6 months, that is completing 2 spermatogenic cycles before going for assisted reproductive techniques. Patients with abnormal testosterone and estrogen ratio may benefit by co-treatment with aromatase inhibitors. This is a moderate recommendations. 30 to 80% of infertile men have elevated seminal reactive oxygen species levels of potentially treatable conditions in these days. Oxidative stress potential is better representative for oxidative stress as it provides an overall measure of the activity of both oxidants and reductants. It's unfortunately that we still do not have a readily available test by the infertility expert. Thank you very much.